Hi everyone, welcome back to our WVS webinar series. We've got a really exciting one today on the management of heat stroke in dogs. It's really topical, really important right now, and we've got Dr. Sumant, one of our lovely vets, returning to give you a fantastic webinar. So please enjoy. If you have any questions, we will answer them. Dr. Sumant's going to provide his email for you to answer them for you at a later date. But if you need anything, just pop it in the chat box. And yeah, check out our other webinars as well if you can. I'll hand over to Dr. Sumant now.
Thank you, Beth. So, good evening, everybody. I'm Dr. Sumant from WVS India. Today, I'm going to present on the management of heat stroke in dogs. So, in this webinar, we'll talk about the physiology of thermoregulation, pathophysiology of heat stroke, how to diagnose it, what's the recommended treatment, the prognosis, and how to prevent heat stroke in pets. As you all know, India is facing one of the worst summers in decades. The ambient temperatures are crossing more than 45-46 degrees Celsius in many places. Heat stroke is a life-threatening emergency seen in pets during summer. I'm sure most of us has come across a few heat stroke cases in the last 2 months. So it is very essential for us to discuss about the management of heat stroke. So let us talk about the physiology of thermoregulation first. So temperature plays a major role factor affecting tissue functions in the body. So dogs are warm-blooded animals. They are homeotherms. They generate their own internal heat through metabolism. They also maintain a constant body temperature in presence of ever-changing external or environmental temperature. The normal rectal temperature of dog is 37.5 degrees Celsius to 39.5 degrees Celsius. That is 99.5 degree Fahrenheit to 103 degree Fahrenheit. Body temperature depends on the balance between heat input and heat output. So heat inputs for an animal comes from its metabolism and from external sources. Heat is a byproduct of all metabolic processes. So metabolism produces heat. Animal also gains heat from external sources by three mechanisms. The first one is conduction. If animal is in direct contact with the hot surface, then it gains heat. The second mechanism through which an animal gains heat is getting exposed to radiant heat sources such as sunlight. Heat transfer via electromagnetic radiation happens without direct contact. The third mechanism is through convection. So heat transfer takes place between body surface and the surrounding air. If the surrounding air temperature is more than the skin temperature, for example, in cases of heat waves, then the animal gains heat through convection. Coming to heat output, heat is lost from the body to the environment by four mechanisms. The first one is radiation. It refers to infrared rays coming from the body. It's a natural process. Any object with a temperature above absolute zero, that is minus 273 degrees Celsius or 0 Kelvin, will emit electromagnetic radiation in the form of infrared rays. The second mechanism is conduction. If the animal is in direct contact with a cool surface, then the animal loses heat to that surface. For example, if the animal is placed on a stainless steel table, it loses the heat to the table. Sorry. The third mechanism is convection. So it is a transfer of body heat to surrounding cool air as it passes over the body. So if the surrounding fluid medium such as air or water has a lower temperature compared to the skin temperature, then the body loses heat. The fourth mechanism is evaporation, where the heat loss takes place by respiratory secretions such as saliva or sweat in the form of water droplets. A small amount of heat is also lost via urine and feces. When ambient temperature is below the body temperature, in normal circumstances, more than 70% of heat loss takes place through radiation and convection. But if the ambient temperature approaches or exceeds the body temperature, then evaporative heat loss is the major mechanism through which an animal loses heat. Coming to temperature regulation, so there are thermoregulators in the thermoreceptors in the body. So there are peripheral thermoreceptors, there are central thermoreceptors. They sense the change in peripheral and core body temperature. So the information from these receptors are integrated in the anterior hypothalamus. The preoptic area of anterior hypothalamus is responsible for thermoregulation. So hypothalamus has a thermoregulatory set point. So if the core body temperature is rising beyond that set point, then the heat losing mechanisms are initiated. If the body temperature decreases below the set point, then temperature conservation or heat production begins. So when an animal is exposed to increased ambient temperature or acute heat stress, the following heat loss mechanisms are initiated. The first one is peripheral vasodilation. Under acute heat stress, the arterioles of the skin vascular bed dilates. The arteriovenous anastomosis open in the periphery, such as limbs, ears, and muscle. So this is the initial response. With this, there is increase in circulation, increase in heat delivery, and increase in temperature of the skin, which facilitates heat loss. Remember that whenever there is peripheral vasodilation, there is subsequent splanchnic vasoconstriction happening in the body as a compensatory mechanism. The second mechanism is as a response to heat stress is evaporative cooling. If vasodilation alone is not sufficient, then evaporative cooling begins, either by panting or sweating or both. As you all know, dogs have poorly developed sweat glands, so they rely mostly on panting for evaporative heat loss. So evaporative heat loss via panting becomes very important if ambient temperature approaches or exceeds body temperature. In fact, this is the only effective mechanism when outside temperature exceeds skin temperature. Animals with any form of airway obstructions, including brachycephalic breeds, because they have decreased nasal terminate area, stenotic nares, they won't be able to utilize this panting efficiently and cannot dissipate heat efficiently via evaporative heat loss. So that's why they're more prone for heat stress, the brachycephalic breeds such as pug, bulldog, boxers, etc. Also, if the relative humidity is very high, then the effectiveness of evaporative heat loss decreases. So you will see more heat stress or heat stroke cases in coastal cities such as Mumbai and Chennai. Animals also use behavioral methods to resist heat stress, such as seeking shade or standing in water. Physiological response to heat stroke also include induction of heat shock proteins. They are the molecular guardians. They protect cell from hyperthermia by maintaining intracellular function and structural protein integrity. Also, acute phase response is stimulated to protect tissue from excessive heat and to promote repair. Similarly, when the animal is exposed to decrease in ambient temperature or cold stress, then thermoreceptors will sense it, and this information is processed in the anterior hypothalamus. So, heat production mechanisms are initiated in that case, such as peripheral vasoconstriction, shivering and non-shivering thermogenesis. So, let's talk about some of the terminologies. So, acute heat stress refers to the discomforts and physical strain an animal feels when exposed to increase in ambient temperature. So, heat exhaustion refers to a severe form of heat stress where animal is dehydrated because of profuse sweating or panting, which results in hypovolemia and subsequent hypotension that results in weakness or collapse. Heat stroke refers to a more severe form of heat stress where there is a failure of thermoregulatory mechanism due to the very high temperature and which is exacerbated by high humidity or strenuous exercise. Now let's talk about heat stroke in particular. Heat stroke occurs when heat production or input exceeds heat output. Heat stroke can damage central nervous system, can cause circulatory collapse, can cause alteration in normal cellular and enzymatic function, and even death. So the definition of heat stroke in human medicine is it's a form of non-pyrogenic hyperthermia associated with systemic inflammatory response, leading to syndrome of multi-organ dysfunction in which encephalopathy predominates. I think we can use the same definition in pets as well. There are two types of heat strokes. The first one is non-exertional or classic heat stroke. This is caused by exposure to extreme high temperature. Th- This is what we generally see during summers. And the second one is exertional heat stroke. This is associated with strenuous exercise. Coming to the predisposing factors can impair the body's ability to dissipate heat or cause increased heat production. The endogenous factors are upper airway abnormalities, such as brachycephalic configuration and laryngeal paralysis. Obesity can also limit heat dissipation by inhibiting cutaneous vasodilation. Thick hair coat can also inhibit body's ability to dissipate heat. Then there are exogenous factors that limit heat dissipation. They are lack of acclimatization, water deprivation, confinement to areas with limited ventilation. So if a pet is locked inside a car and the outside temperature is very high, the air gets saturated with water vapors from panting. So this increases the humidity. So it negatively affects the evaporative heat loss and makes the animal more susceptible to heat stroke. Apart from apart from these, neurological diseases, cardiovascular diseases, and certain medications such as phenothiazines, beta blockers, loop diuretics, they also affect the body's ability to thermoregulate. Coming to effects on organ systems, heat stroke can affect multiple organ systems. Multiple organ dysfunction is the hallmark of heat stroke. So the organ systems commonly affected are gastrointestinal tract, coagulation system, renal system, cardiopulmonary system, nervous system, musculoskeletal system. So the mortality rates in dogs due to heat stroke can be as high as 36 to 50%. Coming to gastrointestinal system, due to direct cytotoxicity and prolonged splanchnic vasoconstriction, this leads to uh, severe hypoxia and increased reactive oxygen species generation, which can accelerate mucosal injury that results in mucosal sloughing and hyperpermeability of mucosa. This increase in mucosal permeability can predispose gastrointestinal bacterial translocation, mainly the gram-negative endotoxins, and can lead to sepsis. The next system that is affected is coagulation system. Direct cytotoxicity uh, causes severe endothelial damage and increased capillary permeability. So this severe endothelial damage activates the coagulation cascade. So this predisposes the heat stroke patients to disseminated intravascular coagulation, or what we call DIC. So because of this consumption coagulopathy, there will be depletion of clotting factors and platelets. The next system is renal system. So direct cytotoxicity and prolonged splanchnic vasoconstriction can also result in acute kidney injuries. More than one third of the patients suffering from AKI will suffer from acute kidney injury. Further renal injury can develop from excessive myoglobin infiltration, secondary to muscle damage, that is rhabdomyolysis. So coming to cardiovascular system, so cardiac myocytes are susceptible to direct cytotoxicity or thermal injury. So this causes conduction defect and ventricular arrhythmias. Arrhythmias are seen in more than 25% cases presented for heat stroke. Then central nervous system, direct cytotoxicity can cause neuronal injury and cell death. So cerebral edema, hemorrhage, they are noted on necropsy in heat stroke patients. Coming to pulmonary system, thermal injury to pulmonary endothelium results in non-cardiogenic pulmonary edema and acute respiratory distress syndrome. So these changes impair in respiratory function and further impair heat dissipation. Direct thermal injury and prolonged splanchnic vasoconstriction can also lead to hepatocellular damage. This can make the animal icteric. Thermal injury to muscle causes rhabdomyolysis. Dehydration due to evaporative heat loss and GI fluids result in decrease in circulatory volume. So this in turn causes decrease in cardiac output. So as heat stress progresses, because of severe dilated vessels and leaky capillaries, the BP of the animal falls and the animal suffer from distributive shock. Increase in core body temperature above 105 degree Fahrenheit can result in permanent brain damage, and at 109 degree Fahrenheit, So there will be protein denaturation, uncoupling of oxidative phosphorylation in the mitochondria, and cell membrane destabilization. This will ultimately lead to cell death. So this is the pathophysiology of heat stroke that we spoke about in brief. Now coming to history and clinical science, history often includes exposure to increased environmental temperature, confinement in areas without shade, water, or poor ventilation, or a history of strenuous exercise without acclimatization. For example, if a dog from a hill station is brought to a coastal area which is hot and humid, the animal needs at least 10 to 20 days of acclimatization. The complete acclimatization may take up to 2 months. So before that, if you put this animal through strenuous exercise, then this animal will end up with heat stroke. The early clinical signs of animals presented with heat stroke includes uh, restlessness, panting, hypersalivation, tachypnea, tachycardia, and rectal temperatures can be between 104 degree Fahrenheit to 109 degree Fahrenheit. In later stages, we see seizures, emesis, hemorrhagic diarrhea, severe weakness, and loss of consciousness. As you can see, the brick red mucous membrane is because of peripheral vasodilation. The petechiae and ecchymosis in the under the skin, ear pinna, and sometimes in the mucous membranes are all because of disseminated intravascular coagulation. Hematuria and hematemesis, melena, they're also due to disseminated intravascular coagulation. In one of these photos, you can see an ectric unconscious patient with acute kidney injury. These are some of the postmortem findings seen in patients with heat stroke. So you can see multifocal epicardial hemorrhage in the heart, hyperemia hemorrhage in the intestinal lumen as well as brain. Coming to patient assessment, the patient assessment and treatment should begin simultaneously. So take a brief history and assess the patient for cardiovascular, airway, and breathing. Check for presence of heartbeat, patent airway, and spontaneous breathing or normal respiratory excursions. If there is no heartbeat or if the animal is apneic, please start CPR, that is cardiopulmonary resuscitation. If the heartbeat is present, then analyze the rhythm and take ECG. If there is any airway obstruction, please intubate your patients. After that, assess the vital perfusion parameters such as pulse quality, mucous membrane color, capillary refill time. This will help you to assess the signs of shock. And then we perform a complete and focused neurological examination. If the patient is presented with altered mental state, then we can use a modified Glasgow Coma scale for the patient assessment. And then we examine unhaired skin and mucous membrane uh, for the evidence of petechiae or ecchymosis, which is manifested because of disseminated intravascular coagulation. We also perform a rectal examination to evaluate evidence of GI hemorrhage, mucosal sloughing, or melena. We also assess the hydration. So this is the algorithm for initial patient assessment. The patient diagnosis should also include CBC, that is complete blood count, serum biochemistry, peripheral blood smear, urinalysis, arterial blood gas, and coagulation testing. The common abnormalities seen in CBC are leukocytosis. This is because of acute inflammatory response. Thrombocytopenia or reduced platelets. It is because of consumption coagulopathy or DIC. There will be increased PCV because of hemoconcentration. And in the peripheral blood smear, you can see a number of nucleated RBCs. You can see in one of the photos on the right top. So those are all nucleated RBCs. So the thermal injury or thermal cytotoxicity of bone marrow causes early release of these nucleated RBCs, which is very helpful in diagnosing heat stroke patients. And also schistocytes or the fragmented RBCs can also be seen on peripheral blood smear. This again indicates disseminated intravascular coagulation. Elevated creatinine kinase suggests damage to muscle, that is rhabdomyolysis, and evaluation of ALT and bilirubin indicates hepatocellular injury. Elevation of ALT and bilirubin indicates hepatocellular injury. Elevation of BUN and creatinine indicates azotemia. It can be pre-renal as a result of dehydration, or it can be renal because of direct thermal cytotoxicity. Elevated creatinine kinase suggests muscle damage, that is rhabdomyolysis. Then acid-base imbalances include metabolic acidosis, respiratory alkalosis, and alteration in the level of sodium, potassium, calcium, and phosphorus are seen. Hyperkalemia can be seen as a result of cellular death, particularly rhabdomyolysis. Hypernatremia can be due to water loss by dehydration, and hyponatremia can be due to increased hypertonic fluid loss due to vomiting or diarrhea. Hypocalcemia and hypophosphatemia may also be seen, but the underlying mechanism is not known. Uh, then urinalysis is very important to evaluate the patient's urine concentrating ability. So a lot of heat stroke patients suffer from AKI and they become oliguric or anuric. So it is very important for us to put an urinary catheter and collect urine and examine every 4 to 6 hours. Apart from this, coagulation testing often shows us elevated prothrombin time, partial thromboplastin time, and presence of D dimers. So this will help you to diagnose what's happening with the patient. Coming to the treatment, the most important aspect of treatment is active cooling. Apply cool water on the body surface, not the ice cold water, just cool water on the body surface. Increase air circulation over the body with fan or AC to promote convective heat loss. So the haired areas of the body, such as ventral abdomen, axilla, and inguinal region, you can use a uh, towel soaked in cool water, and then you can apply the cool water in those areas. So active cooling should be stopped when the patient's temperature comes comes down less than 103 degree Fahrenheit. And the second thing is cardiovascular support. So heat stroke is characterized by distributive shock with volume deficit. So to restore perfusion, fluid resuscitation should be initiated, and we mostly use isotonic crystalloids for this purpose, such as Ringer's lactate or normal saline. If there is hypoglycemia, glucose supplementation is needed. If hypotension persists in spite of adequate fluid therapy, then we give vasopressors such as dopamine, dobutamine, or norepinephrine is considered. Oxygen supplementation also improves tissue perfusion, and the coagulopathy patients may benefit from fresh frozen plasma or whole blood transfusion. If the hematocrit is less than 25%, then you can consider blood transfusion in these patients. And more than 25% of the heat stroke patients, they show ventricular arrhythmias. So it is very essential to have antiarrhythmics such as lignocaine on board. So the next is gastrointestinal support. Proton pump inhibitors are most commonly used, and you can use sucralfate if GI ulceration is suspected. Uh, See, because of compromised GI tract, because of prolonged splanchnic vasoconstriction and direct cytotoxicity, the mucosa will be damaged and there will be hyper perfusion of GI tract. Because of this, bacterial translocation happen and the animal may suffer with sepsis. So in these cases, we use broad spectrum antibiotics. But I would like to suggest that always refer to Protect Me poster from BSAVA. It will give you a guidelines for when to use antibiotics and what antibiotics to use. So, and the next is neurologic support. So, if increased intracranial pressure is suspected and the animal is well hydrated, you can either use hypertonic saline or mannitol to bring down the intracranial pressure. Sometimes, because of electrolyte imbalance and hypoglycemia, the animal may show seizures. So, you need to correct that first. So, these are the different drugs which we use for treatment apart from active cooling. So now let us talk about the things that we shouldn't be doing for our heat stroke patients. So as a beginner, I have also done this mistake, and I know a lot of vets do these mistakes. So I put a slide for things not to do. The first and the most important one is don't use NSAIDs, the non-steroidal anti-inflammatory drugs to reduce the temperature. So the NSAIDs includes meloxicam, carprofen. So because in a heat stroke patient, the GI tract is already compromised, and more than one third of the patients are in acute kidney injury. If you use NSAIDs, it will further worsen these conditions. And the second important thing is don't use ice packs directly on the skin, because or use ice cold water directly on the body, because this will cause cutaneous vasoconstriction and shunt the blood to the vital organs. So again, this will impair the heat loss. You will be doing more harm to the patient than help. And avoid cold water enemas and gastric lavage, because this may further damage the already compromised GI tract. And the last one, this I've seen in a lot of cases, avoid covering the dog with wet towel or blankets. Initially, it may help, but after some time, this acts as an insulating layer and prevents the heat trying to radiate from the body. So, don't cover your patient with wet towel or blankets. Don't do that. Coming to the prognosis, the return to normal CNS function is considered a positive prognostic indicator in dogs that have suffered from heat stroke. There are some negative prognostic indicators at hospital admission. So they include altered mental state or seizures, hypoglycemia, clinical signs compatible with DIC, that is petechiae and ecchymosis under the skin or in the mucous membrane, prolonged prothrombin time and partial thromboplastin time, delayed admission to the hospital, and elevated serum creatinine. These are the negative prognostic indicator for a heat stroke patient. Then, how do we prevent heat stroke in our pets? So, make sure your pets have an access to shade and drinking water during the summer. Avoid taking them for walks or strenuous exercise during the day. You can prefer early mornings or late evenings when the ambient temperature is low. Keep your pets indoor if the outside temperature is very hot. So, never leave your pet locked in a car unattended. Allow time for acclimatization, especially if you have traveled. These are the ways which we can prevent heat stroke in our pets. So these are my references, and if you have any questions, feel free to mail me so that I can respond to you with appropriate reference materials. So I displayed my mail ID in this slide. And also there are QR codes for WS Vet Academy and YouTube channel in this slide. Whoever is interested can go through the channel. There are very useful webinars, and we have planned many more webinars in the days to come. So, so that's it. Thank you.